Every day, providers confront the chaotic variability of human illness. The challenge is capturing that messy biological reality, translating it into standard, actionable data. The solution to this translation problem relies on the overarching guidelines of the ICD-10-CM coding system. This layout displays guideline B.3, which dictates exactly which alphanumeric ranges are authorized to describe a patient's condition or reason for a visit. A00.0 through T88.9, Z00 through Z99.8, and U00 through U85. Coding transcends a simple inventory of diseases. It catalogs the totality of the patient's circumstances. These approved ranges map out an exhaustive ontology, capturing everything from internal physical states to the patient's external environment. Understanding these specific code blocks means recognizing the total information architecture required to document a patient encounter without losing critical clinical data. This diagram illustrates the foundational block of that architecture, the A through T range. This primary database is strictly used to log confirmed diseases, physical injuries, and specific physiological conditions. It also accounts for external causes, answering the question of exactly how a physical injury occurred in the patient's environment. We must also account for encounters where a definitive diagnosis has not yet been confirmed. Even without that confirmed disease, the A through T range provides the specific codes necessary to document the patient's presenting symptoms and physical complaints. This block serves as the system's primary method for logging the direct physical manifestation of a patient's health issue. Now consider a different clinical scenario. A patient interacts with the healthcare system, but they are not actively sick, injured, or presenting any symptoms. This updated diagram highlights the second structural block designed specifically for this scenario, the Z00 to Z99.8 range. Z codes capture encounters for baseline medical services, such as routine annual exams, post-operative checkups, or preventative screenings. They also track external factors influencing a patient's health status, providing vital context that a purely physical disease code cannot capture. This introduces a common industry failure point. Coders are frequently conditioned to look exclusively for active diseases, causing them to completely overlook relevant Z codes. When active illness is absent, Z codes document the explicit reason for the metaservice, ensuring the encounter is legally and clinically justified. Occasionally, the healthcare system encounters novel threats. The World Health Organization reserves them specifically for emerging conditions and novel viruses. By utilizing U codes, local healthcare facilities can instantly feed data from individual patient encounters into macro-level epidemiological tracking and public health databases. The existence of the U range proves that ICD-10-CM is a living, adaptable architecture capable of responding to real-time global health crises. How does a coder actually interact with these three distinct databases during a single complex patient encounter? This diagram shows all three data pillars fully illuminated and converging. Accurate reporting requires a combinatorial approach because a single code is rarely sufficient to describe a complete clinical scenario. You must capture both the exact physical condition and the overarching reason for the encounter simultaneously. Relying on the single code fallacy is a severe operational error. Failing to assign all necessary codes across these ranges guarantees incomplete clinical documentation. Data loss creates cascading consequences, leading to incorrect regulatory reporting and significantly reduced reimbursement. Accurate coding requires the deliberate construction of a multi-code matrix drawn from the entire A to U spectrum. This entire scope can be synthesized into a single operational anchor. A to U covers U. From A00 to U85, the architecture inherently possesses the capacity to capture the entire narrative of a patient's story. This leads to a primary directive: always code the condition and always code the reason. This architectural standard holds universal jurisdiction. These specific code ranges govern clinical data across inpatient facilities, outpatient clinics, and individual physician offices. As a medical coder, your ultimate responsibility is to operate within this framework accurately. Mastering the A to U landscape is the only way to synthesize a complex human encounter into a complete and accurate clinical picture.